there have been a lot of relapses. Relapses, I mean recurrences of reactions, and therefore it would not serve the purpose the way it is wanted. So there have been other studies. The only study, I suppose, in the documented literature is by Rao et al. And this prednisolone regimen, they've designed it basically a high-dose regimen. You can see it started with 60 milligram and tapering over every fortnightly, and then maintained it for 8 weeks and followed up for 1 year. So the total duration of prednisolone was 2.94 grams over a period of 3 months. So started with high dose, but then tapered off up to in 3 months, and then followed up for 1 year. Why was the follow-up done is to see whether there are recurrences. And this particular regimen showed that additional steroids required during 1 year was 46%. So which means again this could not serve the purpose. This was compared with another regimen which was called a low dose regimen. So they gave initial dose of 30 milligram, and you'll find that when you drop to 20 milligram, this was maintained for a little longer period. It's almost about 8 weeks, and then tapered, and then you stop. So here if you find the total dosage of prednisolone is 2.31 grams, but the duration was 5 months, and the additional steroids required was 31%. So there's a big difference between these two regimens, and the difference is in terms of recurrences can be prevented. At the same time, the duration is increased. Now we have been practicing at our referral center, as I mentioned earlier, a couple of steroid regimens as to see what works better, given this paucity of information as on this important and vital aspect. So we had one schedule where we started with 60 milligram and then tapered over weekly initially, and then fortnightly, and then maintained once you drop to 20 milligram or for a longer period. So the total dose required was 4.69 grams, and this was given over a period of 7 months. And we found, again followed up for 1 year, or for if possible even more than 1 year, and the total additional steroids required was 16%, which means the recurrences can be contained to a great extent. This was compared with another low regimen where you started off with a lower dose and then tapered off over a period of 5 months. The total dose required was 3.08 grams, but the steroid requirement was very high additionally afterwards. So the message that comes from this is, and that suits the problem also, is that you need to keep the steroid for a little longer period, and can't be tapering off drastically and in a fixed period. Particularly the threshold dose. What we talk of threshold dose, when we see clinically, you see patients when they come down to 20 milligram, they throw off a reactions. 15 milligram or 20 milligram, which means possibly this is a threshold dose, and therefore it will have to be maintained for a reasonable period of time, and that can contain the recurrences. Now coming to another drug which is underrated and underestimated and underutilized. Clofazimine, the role of clofazimine is in type 2 reactions. We often find patients with type 2, as I mentioned, ENL reaction, often treated, and then they coming back with recurrences, and that's how again the ENLIST group again decided to define what is acute, what is chronic chronic ENL or a recurrent ENL. This is very important. So in such cases, you can add a drug like clofazimine, and that has to be given in the higher anti-inflammatory dose, particularly 300 milligram in divided doses, and that will take at least about 6 to 8 months or 6 to 9 months for a pretty long period to show its demonstrative action, and there it can help to wean off patients with being on long-term steroids or steroid adverse effects or steroid dependency. And you can maintain the patients on clofazimine for a long time, at the same time preventing recurrences further. But you'll have to start along. You can't start clofazimine straight away and then expect a result, because it will take at least 6 to 8 weeks to show its action, and therefore you'll have to couple it with prednisolone initially for a shorter period and then stop it. Now, this is a list of drugs, the entire list of drugs which are used. You can see here the corticosteroids on the top of the list in type 1 and type 2. Thalidomide only in type 2, because I've seen people treating type 1 reaction with thalidomide. It has no role. I've seen patients who have been referred and been given thalidomide for months together. So thalidomide has no role in type 1, and type 2, excellent drug. Clofazimine, I just now talked about it, type 2, but look at this, type 1 also. I'll come to that. Pentoxifylline plus minus. You have cyclosporine, azathioprine tried in very good double-blind studies. Unfortunately, the studies have not been helpful in concluding that this can be used as a very good drug. But then, in some cases, offhand, it may have its role. Methotrexate is one of the drug where we are planning a double-blind controlled multicentric study in ENL reactions. The other drugs are all of debatable value, and that needs a lot of studies. Now, the thalidomide regimen, which is what is practiced, is commonly is basically to start with 300 milligram. It's an excellent drug. I'm sure you must be using it here, and the only thing is you have to look into the adverse effects, the precautionary measures, particularly in the reproductive age group, and that will have to be taken care. Otherwise, it's an excellent drug and it can be given for a long time. Now, the problem is, again, we found there is a recurrence even after giving for a longer period. We have given thalidomide practically up to 2 years, 18 months, 12 months, 18 months, 24 months. Expensive drug, the cost factor comes into an issue, but you can prevent recurrences, wean off patients, save patients, rescue patients from the miserable pain of ENL reactions. So this is what the group defined is acute ENL or a newly diagnosed ENL occurring in an individual for the first time. Recurrent ENL is a second or a subsequent episode occurring 28 days or more after stopping treatment of ENL. And you have chronic, some patients do keep on throwing off ENL reactions, chronic ENL, which is occurring for 24 weeks or more, practically 6 months to more, to which a patient he requires ENL treatment either continuously or where the treatment period is less than a month. So which means he cannot be put off the drugs. The moment you withdraw him from the treatment, he will throw off. And NFI is a reduction in the sensory, motor or autonomic function. So chronic ENL are awful troublesome and a challenge, and that impairs the quality of life of an individual. So quality of life of this type of individuals are also into a study where we have been, according to WHO quality of life, the factors are taken into account to study the QOL. So the maintenance therapy with steroids, in such cases, therefore you are bound or you are tempted to give steroids very often. And some people say that you can manage that particular episode with giving a short course and then taper it off. But then the problem of dependency or a kind of an addiction or adverse effects, the risk is more. And therefore you will have to look into other factors, like as I mentioned, precipitating factors. There was a patient where HIV along with leprosy and ENL reactions, and HIV was not known about this, and he was keeping on throwing reactions. Similarly, a case of tuberculosis with leprosy. Leprosy TB, the association is quite predominant. Leprosy HIV association is not very very common as compared to TB. So you will have to treat these underlying factors, and when you treat them, you will see the management of such chronic reactions becomes much more manageable. So I was mentioning that even our experience, even with maintenance therapy for an average period of 8 months, we found a recurrence of 19%, 20%, which means the therapy will have to be with thalidomide for a longer period. So these are some other drugs which are in the pipeline, but then they are not yet what you call studied, and particularly thalidomide analogs and immunomodulators like lenalidomide, which is a drug which is already in use for lymphatic myelomas and other malignant conditions. It is available in India, but is highly expensive, very, very expensive, more expensive than thalidomide. Pomalidomide is not available, but then this is also one of the drug. And the azathioprine and other immunosuppressants has been tried, but then not of much success. So that brings us to silent neuropathy or quiet nerve paralysis. If not identified early and managed promptly, this will add to the disease pool, the burden of leprosy-induced disability, which is already to the extent of, say, 2 million in the world. And therefore, regular nerve function assessment is essential. Though this assessment with the help of monofilaments, particularly early nerve function impairment, is being documented very well, and therefore SW monofilaments is used to measure diminishing and returning cutaneous sensations. These are nylon filaments. About 6 monofilaments are in use, as you can see in this picture, of various calibers. So this particularly assessments with the help of nerve function impairment, this will help us to identify nerve function damage much early. And there are certain signs with respect to particular every nerve, the very common nerves, that you can identify them early and then put them on aggressive management so that you can reverse the nerve damage that has happened. The nerve damage, the history, or if you can assess periodically and find out if the nerve damage is less than 6 months to 1 year, then you can do a lot more justice to these patients. These are some of the patients who are managed with thalidomide. This patient is a relapse, and he threw off ENL reactions. After he relapsed, very severe ulcerative necrotic renal reactions, to the extent that he was highly depressed and then even contemplating suicidal tendencies. So we had to put him on thalidomide for quite a long time, and now he is with severe scarring on all the affected areas, severe puckered scarrings. This is another girl, a young girl, who was referred to us from a distance of almost 80 kilometers. She was already treated, as you can see, already treated with the anti-leprosy drug, but what she was left with the residual nerve damage. You can see this nerve damage happened after the treatment. With the right hand, you can see the claw, and then luckily the duration was less than 6 months, and then we started her on steroids in the schedule which I showed earlier, coupled with physiotherapy measures, and you can do a lot more justice to such individuals non-surgically, conservatively. Another young boy, very young boy with the claw hand, again treated but left with nerve damage, left with disability, and you can correct it again with conservative management, not resorting to any reconstructive surgery. The other aspect in a challenge, clinical challenge, is facial patches. Involvement of facial nerve and of zygomatic branch is well known, leading to weakness of orbicularis, oculi muscle and leg of thalmus, which is a severe ocular complication. And appearance of any type 1 reaction puts the patient, particularly lesions on the face, puts the patient at risk of nerve damage and deformities. These are some of the photographs. These are some of the clinical photographs where you can see this is a a young man of 35 years, but the leg ophthalmos was very short duration, 1 month. So if you can pick up these early lid lag or the leg ophthalmos or the gaps in the closure of eyes, and then treat them with the scheduled optimal course of prednisolone, you can reverse the nerve damage. That's what I would like to drive at. Another example, 35 years, again early, just 1 month, but bilateral leg ophthalmos, and again treated with a standard course of steroids coupled with physiotherapy, the nerve damage can be reversed. This lady came to us, a taxi driver from Bombay brought her right from UP, because he was a patient with us, and then he called her from UP all the way. I said, why did you call her all the way to Bombay? You could have jolly well treated her in UP, there are several centers. But then he brought her to Bombay, and then when I saw her, he just walked in one day, and when I saw her, there have been diffuse infiltration of the face, took a skin smear which turned out to be 4.3 plus. She had bilateral leg ophthalmos and started off first with steroids. I started off steroids and physiotherapy. This was, you can see the date, this is June 2012, this is July 2012. In 1 month, this could be reversed, because the diagnosis was, you could do an early diagnosis and you can reverse the nerve damage. Later on, we put her on the anti-leprosy treatment. That issue is different, but to correct the nerve damage, to prevent the nerve damage, the diagnosis has to be done. So prednisolone is the drug of choice. Contraindications, side effects, adverse effects are too well known, and that should be kept in mind, and this has to be impressed upon the health workers and also on the patient. We often give a due date card, we give a steroid card to the patients so that they remember. It is not easy to follow steroids for such a long time, and therefore if you got to have the compliance in hand, if you got to hold the patient and visualize this type of result, then you got to have a very good compliance and vigilance. So even defaulters, steroid defaulters, we track them. We send our volunteers and track them and bring them back, or make a phone call. Nowadays, even patients have mobile cell phones. So take their numbers, and so that you can contact them, those who are defaulters. Otherwise, we won't be able to lay our hands on this type of results. So therefore, the patients will have to be counseled, they will have to be motivated to complete not only the course of your standard treatment, but also the course of steroids. And therefore, we have a different card where due dates are there. This was a patient referred from, again, Jalgaon, 600 kilometers, with severe necrotic ENL. We had to treat him with thalidomide. Of course, it left with a lot of scarring. Some of them do tend with hypertrophic keloidal scarring, puckered scarring, stellate scarring, all sorts of things are there. This is to highlight the lymphadenopathy. This man, no ENL, but lymphadenopathy was the predominant factor, and we'll have to treat him with thalidomide. And with thalidomide, you could completely resolve the lymph node enlargement. And thereafter, he is quite well maintained, quite happy, and there has been no recurrences. Type 2, again, another example of a thalidomide treatment. It's an excellent drug. Only thing is, we'll have to look into its limitations, the cost, and the adverse effects. In fact, in Brazil, it is the first line drug. In India, we take it as a second line drug. Steroid is the first line. But in Brazil, thalidomide is the first line drug. Steroid comes afterwards. So, and in some countries, thalidomide is not available. For example, Bangladesh doesn't permit thalidomide. And Sri Lanka, they have